Okay. I think we're going to get started as folks trickle in, grab some food. For those of you who don't know me, I'm Ryan Kimmel. I'm one of the psychiatrists over at the UW Medical Center. And I help organize the speakers with Sharon Rahm here, although I usually watch online from afar. Today I'm on parole temporarily out of the medical center to come over. So Sharon and I periodically like to have speakers to talk about certain subpopulations in terms of substance abuse issues and mental health issues. And she and I have, by virtue of our inpatient psychiatry work, have both hospitalized physicians in recent years and have used the Washington Physicians Health Program as a follow-up program and things like that. And so so we decided that this time the subpopulation we would talk about would be us, so to speak. So Chris Bundy was well known to us. He is now the executive medical director of the Washington Physicians Health Program, but spent 15 years on our faculty and was the director of acute mental health services at Harborview and trained in addiction and geriatrics. And so he's who we called on to come talk to us. So thanks for coming, and I'll let Chris do his thing.
Thank you. Good afternoon. So I'm Chris Bundy. I'm a psychiatrist, adult and geriatric. I'm also addiction medicine boarded. And I've been with the Washington Physicians Health Program. Can you all hear me? Okay. By the way, for about 4 years now. It has been a mission that is near and dear to my heart. It's not a secret that I'm in long-term recovery myself from a severe alcohol use disorder. And I put that out there because I think we often don't really know what addiction and or what recovery looks like in physicians. We don't get a lot of exposure during our medical school and training to what addiction and impairment look like in our colleagues. And there are a number of reasons why I'm here to talk to you today. One is I've had a few occasions, certainly Ryan and Sharon know about WPHP, know what we do, and know how to access us and the support and services that we can provide to physicians who are really in trouble. But a lot of people in our department, frankly, don't know who we are or what we do or what our mission is. And I've had occasion in the past year to be reminded of that in various sorts of interactions that have happened in other circumstances involving the UW universe. So I thought, well, this is a good opportunity. I've been faculty in the department a long time, and it's a little embarrassing to me, frankly, that my own department doesn't really know what it is that I do. So I was hoping to kind of give you all a bit of a, I'm going to remind me tomorrow. Is that okay? A little bit of an overview of what it is that we do. Second, there is confusion. There is misunderstanding about what we do. And largely that's because of misinformation about what we do in the medical media and other places. We are bound by being a vault of confidentiality, which means people come to us, things happen, and people talk about their experience, and we can't talk about our experience. So that there's often two sides to a story, and what people hear is not the full story. So I wanted to talk a little bit in more general terms about some of the things that I think are misconceptions about what it is that we do. Finally, psychiatrists are an important group to talk to about this for a couple of reasons. One is psychiatrists are overrepresented among impaired physicians. So if you look at studies that look at treatment populations of physicians, and if you look at participants in physician health programs around the country, psychiatry, emergency medicine, anesthesiology tend to be overrepresented amongst this population for reasons that we could spend the rest of the time speculating on, but won't. The other thing I think that's important is you are all on the front lines of assessing individuals who might be impaired, whether you're working in the psychiatric emergency room, on the inpatient unit, or seeing an individual physician or healthcare professional in your practice. It may come up for you from time to time. Is this individual, this physician who is my patient, are they actually safe to practice with what I know is going on in their life? And I think you have to understand what your obligations are, ethically, legally, and humanitarianly, which is not a word, but I'm going to use it anyway, in terms of sorting that out. And I think the other reason I'm here is to say, this ain't easy. Some of the most difficult situations that I've seen physicians struggle with in their careers is dealing with a colleague where they have concerns that there may be impairment or there may be an impairing illness problem. It brings up a lot of challenging issues for reasons that I'll go into in more detail. So we're going to talk about impairment. I'm going to give you the legal definition. We're going to talk about your obligations around impairment, because I think people often don't realize that they have some mandatory legal obligations around impairment, the same you do to protect children and to protect people from harm, vis-a-vis Tarasoff. Identify signs of impairment. So we'll talk about what does impairment look like, what kinds of things might you see in an individual who could be suffering from an impairing illness. Then I'm going to talk about WPHP and sort of help people understand what the process is. And then I'm going to show you some data, some outcomes from our program that I think show what we do is effective and beneficial to the participants. This is my car, 10-year-old Camry hybrid. This is the good side. There's another side that's got the bicycle marks from the kids and all of that stuff. But I'd drive a better car if I had some commercial interests or conflicts. That's all I'm saying. So this is my proof that there's no, and if you have a conflict to propose to me, I'll be outside after. So to just sit with this for a minute as we talk, a third of physicians are there's not hard data on this. This data comes from a bunch of different sources, and then you've got Dr. Leap and Dr. Fromson who are pulling that together to speculate that about a third of physicians will have an impairing health condition during their career, and about 1% to 2% of physicians in a given year are impaired. So in a hospital of 100 physicians, you're going to have 1 or 2 at any particular point in time who are practicing under conditions of impairment. We have a lot of ideas. Professionally, we're exposed. I'm going to talk for a minute. In order to really understand physician impairment and to understand the challenges that are inherent in addressing physician impairment, we really have to understand, I think, a cultural backdrop upon which we understand illness and impairment in physicians. And then we have to also understand a little bit about where we come from and what makes us unique, a unique species, if you will, of human beings. So some of you may remember the show from the 90s, ER. I certainly remember ER. And Carter, who's here, ultimately needs opioid pain medication for an injury sustained while at work and develops a substance use disorder. And in a very, I think, fairly accurately portrayed episode called Mayday, the episode kind of goes through the struggle that his colleagues in the hospital have, and he has, in sort of coming to terms with what needs to happen next. Has anybody read The Tennis Partner? It's a great book. One person, I highly recommend it. It's a nice inside look. Another, again, an accurate, I think, portrayal of what substance use disorder impairment can look like in a trainee. Does anybody know who the guy is in the hat and the cute socks in the bottom corner? That's William Halstead. He's one of the big 4 founders at Johns Hopkins, pioneered aseptic technique in the OR, invented inguinal hernia repair, gallbladder surgery, radical mastectomy, and cocaine dependence. He was one of the first individuals to use cocaine on himself as he developed experimental anesthetic techniques, and in the process got himself addicted to cocaine, which he then treated with morphine, and he got off the cocaine but remained on morphine for the remainder of his career. Probably not safe, but not unlike our good friend House here, who portrays an image of a doctor who can function with chronic pain and opioid dependence and not put patients at risk, right? So that's a very, I think, mixed message out there in the media. Again, another mixed message is this photo, which was featured in an article in Men's Health magazine several years ago. I don't think that individuals who divert OR medication for their own use typically would go to the trouble of gloving up before injecting. So we know that this isn't actually a picture that was taken, you know, it's sensationalized. And I think that's important to understand, is that when physicians are involved with an impairing illness and it hits the press, it often is highly sensationalized, highly public, and undermines the public trust in our profession. So just some things to think about. And then we've got good old Marcus Welby. And I didn't talk about Marcus Welby, but the reason I put the picture up here is because all of this is happening in a backdrop of this pillar that society puts medicine on, and some of these images of medicine that we've gotten over the years of perfectitude and grace. So going back, it's my boy, this is a few years ago. He, I don't know why he wants to become a physician. I don't know that he does. He tells me he wants to be a pulmonologist. I have no idea where he got that from. He didn't get it from me. Says he likes lungs. So I think, you know, most of us probably put together some version of, I want to help other people on our medical school application. It's what we learned to say when we went to the medical school interviews and beyond. And it's not untrue. And physicians have these remarkable backgrounds. When you look at physicians' backgrounds, they come from incredible, often diverse socioeconomic backgrounds. They have diverse histories, including trauma histories, and deep, rich experience that they bring that I think plays into that desire to be helpful to others, having maybe needed help for oneself at some point in time. And I think that it's kind of a psychological law of nature that we choose what we choose because of who we are, right? Why did we choose medicine for a career? Well, in some ways to help ourselves, and probably chose psychiatry as a career, ultimately, in some ways, to help ourselves. So what do we know about this? Well, Glenn Gabbard, who's probably one of the world's leading authorities on personality and physician personality, and run the Gabbard Center out of Houston for many, many years, evaluated thousands of physicians over that time. Well, this is way back from '85. And what he said is basically physicians are compulsive, right? Big surprise, newsflash. We are compulsive by design. And what he argues is that physician compulsivity is something that exists prior to our entry into medicine, that we choose medicine because of our compulsive traits that may derive from unconscious fears of death acquired during childhood, feelings of inadequacy and helplessness, and wanting to get control over that which seems uncontrollable. So we paradoxically choose a profession where we're ultimately faced with, on a daily basis, the limitations of our abilities to control anything. Worth as lovable objects. We self-sacrifice in the service of others. It's a core professional principle. And we learn that self-assertion, or saying no, or setting reasonable limits and boundaries is a path to alienation or separation or sacrifice. So, and Gabbard argues, looking at other data available at the time, that this seems to be unique to physicians. So lawyers, for example, don't score high on compulsivity the way that physicians do. But remember, he's not talking about pathological compulsivity. He's just saying, this is good. This is the way physicians are wired, and it's socially desirable. I like my doctor to be compulsive, thank you. Do you not want a compulsive physician when it comes to your own healthcare? Yeah, I think we all do. The point here is to not pathologize, but to say there's a way that we are in the world that is probably overdetermined our choice to enter medicine, and then gets reinforced over and over again through the process of medical school and training. And what happens when something gets reinforced? So the compulsive triad that he describes is guilt, self-doubt, and exaggerated responsibility, right? So we feel bad if we don't spend as much time as we should studying, preparing for our boards. You know, we can't enjoy our run anymore because we think we should be doing something else. We try to go to a movie, but we should be, you know, checking on those patients' labs, not enjoying ourselves. Self-doubt, so recurrent self-doubt leading to check and double check in a classic compulsive way. And then this exaggerated sense of responsibility, right? So we think that we're in control of the outcomes. Right? And we get this reinforced over and over and over again through our training. It's like, if you're a good doctor, then you'll get good outcomes. And if you get bad outcomes, you're a bad doctor. And I'm here to tell you that is a roller coaster that is not sustainable over a 40-year career in medicine, right? So this leads to difficulties that we're all familiar with: overwork, denial of our physical and emotional needs, difficulty with leisure, unstructured time. Oh my God, I have nothing to do. What do I do? Right? We don't know what to do when we don't have anything to do. It's like unheard of. Setting limits, and then our personal relationships suffer. So this starts really in medical school, probably before, and I invite you to just sort of think about there's the regular medical school curriculum, and then there's the hidden curriculum of medical school. And this is where we start to reinforce sort of maladaptive coping strategies that allow people to perform at the cost of routine maintenance and care, right? This is where it starts. So first of all, we walk into a cadaver lab on the first day of medical school and say, here's a dead body, go play with it for a few months. I hate to break it to you, but that is not a normal human experience, right? We have to do something in our minds at that point in time so that we can perform, so that we can learn, so we compartmentalize this kind of horrific thing that we're forced to deal with in an effort to perform. And that becomes a theme throughout the remainder of our career. We go to our first code as an intern. You know, it's distressing, it's anxiety provoking. Maybe the family's in the next room at their wits' end about what's occurring. And not a good time to sort of sit around and emote with the team about your psychological reaction to what's happening, right? No, we learn the ABCs. So again, we can compartmentalize what is normally an intense emotional experience and perform. Right? So over and over again, we reinforce this compartmentalizing aspect. We learn that we can't go to the bathroom when we need to. We don't eat when we're hungry. We don't sleep when we're tired. So we basically disconnect the check engine light, right? That we all have, that most people walk around with. I'm hungry, I'm gonna eat now. Not you. You gotta stay on rounds. Doesn't matter how hungry you are. Nobody cares that you're hungry. You know, there's another patient to be seen. We also send our representatives. Right? So everybody walks in the hospital every day with having sent their representative. They're not, we don't embrace vulnerability, imperfection. We embrace perfection, competence, portraying a highly professional image. And so we send our representative, right? It's like a first date. You don't show up for a first date, you send your representative, right? Over time, you may actually show up yourself when that starts to feel safe and when it feels safe to be vulnerable. But every day in the hospital, we have to portray a different image to our colleagues, and we don't encourage the expression of vulnerability or imperfection. And then we stop doing the things that we were doing at one point in our life that felt like they were good for us. Exercise, eating healthy, these things, sleeping normally, sort of go by the wayside again in an effort to meet what are ultimately unattainable performance expectations. From the minute you start medical school, you are given more information to learn, more skills to learn than anyone can possibly master, which then leads almost every medical student, regardless of how competent they may appear, to express the view at some point or another that they feel like they're incompetent, that they feel like they're an imposter. When you ask medical students about this, this is almost a ubiquitous experience. But how much does anybody talk about having that experience of feeling like they're not good enough, feeling like everybody else in the room is better than them, and somebody must have made a mistake, and soon they'll catch on and they'll be exited from medical school or residency, right? So again, overt and covert messages to perform at the cost of routine maintenance. So we begin to ignore our self-care and we begin to become lacking in awareness of when we're not doing well. And as I mentioned, there are all sorts of reinforced behaviors that on one end of the spectrum are good. These are things that we want: detail orientation, compassion, being helpful, being ethical, being conscientious. But on the other end of the spectrum, when they're overly reinforced, they can become maladaptive. And often what gets us to medical school and training is not what will sustain us during the remainder of our careers in medicine. And I think that's important. At some point or another, we have to make a shift into becoming a different kind of individual where the things that were effective for us and made us successful no longer work. Now, this is all happening on a backdrop, right? Because of these unrealistic standards of invulnerability and perfection, fear, shame, stigma, and denial are all brought into sharp contrast. So a physician who has depression, a physician who has a substance use disorder, a physician who has an anxiety problem and because they had a bad outcome as an anesthesiologist with a difficult to intubate patient, and the patient ultimately died and now can't go back and see patients like that because of the PTSD that they have related to that. We see all manner of things, right? But these things are heightened because of these unrealistic expectations. A physician just shouldn't have these kinds of problems. That's the message. And we've been around for 32 years as the Washington Physicians Health Program because we all recognize that physicians get sick like everybody else. 30% of medical students and 30% of residents have either clinical depression or significant symptoms of depression, score very highly on standardized assessment scales for depression. This is the MATA study. There's a similar study that came out in 2016 for medical students, but there's a significant amount of psychological distress that's occurring at the level of medical student education and training. So it already has begun, this high level of distress. We take students who are entering medical school who are psychologically more well-adapted than their age and education matched peers, and by the second year of medical school, they are more psychologically maladapted than those same peers. So there's something that's happening along this process, and it appears to continue. And I think we need to reevaluate the statistics on the incidence of, and prevalence of depression in physicians. The old data really says that there's no difference in depression between physicians and non-physicians. But I think looking at those statistics that are more current from medical school and residency, and looking at the rate of burnout, which seems to be affecting over half of physicians in the United States right now, there's reason to be concerned that maybe these rates are changing. But what we have known for a while, and certainly Dr. Sung could come up here and finish the day talking about this, is that the suicide risk relative to gender match controls in the general population is much higher for physicians than it is for non-physicians. And interestingly, you see this much higher relative risk in female physicians versus male physicians. Now, female physicians never catch up to male physicians because the rate of suicide completion in males in the general population is at baseline so much higher. But it is concerning. Does anybody have a thought about why we might see this differential risk in females? Double job. Anyone else? Yes.
In comparison to the general population, female physicians have more knowledge about need.
Absolutely. Other thoughts? Yes.
Female physicians may be more liable to kind of overinvest in that role as a caregiver, even if it's possible to time manage that and practically do that for patients.
Yeah. I think that there are many, all of these things are, I think, valid and accurate things that have been postulated. If you think about how females typically end their lives, it's through overdose death and asphyxiation, and physicians would certainly have more medical knowledge, I think, that would increase their capability of being successful. And one of the things in Joiner's theory of suicide that predicts suicide is actually having the confidence that you could successfully end your life. And so I think physicians having both that knowledge and those means possess the confidence as well to end their lives, which may account for some of the differential risk, among the other things mentioned. Again, this idea that things begin in medical school. So 30% of medical students develop a problem with alcohol during the time that they're in medical school, and that's more likely if they're burned out. And going back to that issue of female versus male, female physicians appear to have a higher rate of burnout than male physicians, maybe because of these same kinds of things, dual role, and a tendency towards greater empathy, perhaps, as was suggested. We know that greater compassion and empathy seem to be associated with a greater risk of burnout. Let's talk about impairment. So impairment actually has a definition in Washington State: inability to practice with reasonable skill and safety to patients as a result of a health condition. And I point out health condition, health condition, health condition. We are the Washington Physicians Health Program. We are not the Washington Physicians Assess Your Competency to Practice Program. In other words, I don't know if you can practice interventional radiology competently. I am a psychiatrist. I have no idea about that. But what I can do is evaluate health conditions and whether or not they are potentially impairing you. So really, when somebody gets referred to WPHP, the key question is there a health condition present that's potentially impairing this individual's ability to practice? No health condition, no impairment, right? So that's important. Illness does not equal impairment, right? Illness occurs on a spectrum. Just because you're depressed doesn't mean you're impaired because of your depression. Just because you like to party on the weekends doesn't mean that you have a substance use disorder or you're impaired, right? So we understand that there is a spectrum of illness, and only at an end of that spectrum does impairment come into place. Impairment is a functional classification. It's really on or off. You know, is the individual impaired? Are they not impaired? If they are impaired, how so? As I mentioned, or maybe I didn't, every Department of Health license holder, so beautician, vet tech, physician, dentist, is an obligate reporter of concerns of impairment. So where does this come from? What is your ethical and professional responsibility? So the AMA Code of Medical Ethics, which was revised in June, really speaks to a number of issues. First, we're held to a higher standard in terms of our health and our well-being because of the public safety issues, because when we're sick, we put patients at risk. Society permits physicians to set the standards, to self-regulate, as long as we hold one another accountable. Some would argue or have complained that physician health programs can be coercive or heavy-handed. Coercion doesn't apply to a privileged group of individuals like physicians, first and foremost. Typically, coercion is used to apply to individuals who are vulnerable. So we talk about coercion in research subjects. We talk about coercion in prison populations. We talk about coerciveness with children. We don't talk about coercion typically with professionals. And the social contract really says that you have the privilege of practicing medicine so long as you do so in a way that your profession deems as safe, right? So it's not a right to practice medicine, it's a privilege, and you have to do so safely. You have to maintain your health and wellness. So you have to, according to the Code of Ethics, maintain healthy lifestyle habits. I break this regularly. I had a bag of Cheetos last night, I'm gonna tell you. And you should have an objective personal physician. Physicians take care of themselves, and they shouldn't. They self-prescribe. Please don't do that. I don't wanna see you for self-prescribing, you know, just because you made a mistake or a bad choice. And you may or may not have a substance use disorder, may not be related to that at all, but we should not self-prescribe. We should not self-treat. We should not order lab tests on ourselves that we then self-interpret. We should not order diagnostic imaging on ourselves, which we then self-interpret. And there's data to support that we do all of these things. Less than half of us have a personal physician, objective. We often have a physician that we talk to now and again, usually a colleague or a friend who's in the field who we might run a question by, and then we go ahead and take care of it ourselves. Not a great idea. Prevent and treat illness and self-impairs. So we need to have an honest assessment of our ability to practice safely. Now, what's the problem with that? Honest assessment, that's our ethical obligation according to the AMA.
Can't assess ourselves.
Right, I mean, isn't there this relationship between, don't we see this in our day-to-day work, that there's this often inverse relationship between illness severity and insight? Right? So we might not always know whether we have the ability to practice safely. That we're supposed to take measures to mitigate problems, ultimately because our first and foremost goal is to protect patients. We need to seek help when needed, and we often don't. So you're legally obligated to report concerns of impairment, and that WAC is misprint. It should be 16-200, because I know a lot of you are going to go look this up afterwards and want to get it just right. What does that mean? That means that you don't have to know somebody's impaired to make a report. That's not the standard. How could you? Right? You'll never have that level of certainty. You know, that's my job. That's all I do, is figure out whether somebody's impaired or not. You are going to experience this infrequently in the course of your careers. You can't possibly have the experience or expertise to do that. So The issue is whether you have a concern. And I'll talk a little bit more about that in just a minute. And you have a choice. You can report to the disciplinary authority, in other words, the medical board, or you can report to us. We ask that you report to us because we are a confidential therapeutic alternative discipline. In other words, by statute, you can come to WPHP, we can evaluate the issues, we can make referrals for additional treatment, and we can monitor individuals who need to be monitored, all without the medical board ever having to know anything. And that's really important because having a therapeutic confidential alternative encourages earlier intervention before things get out of control. Once things get out of control, once addiction, impairment shows up at work, the likelihood of having professional consequences that will ensue that will not be confidential goes up. So we endeavor to get to people early before we have those problems to deal with. If we have those problems to deal with, we'll help those individuals deal with those problems. But we'd like to get involved sooner than that. An individual is immune from civil liability for making a report. You are not immune from civil liability for failing to make a report when you should have. So our human responsibility. This is Kim Jones. It's a fairly well-known case from Cadillac in Tri-Cities. Kim Jones was in for an elective tubal ligation after delivery of her third child, didn't want to have kids anymore, underwent the procedure uneventfully, but was being attended to by an impaired anesthesiologist, Robert Berry. It's all in public domain, so I'm not disclosing anything here that I shouldn't be. Who extubated her early. She had a severe anoxic brain injury and never woke up. The organization was sued and lost $8 million lawsuit in this case, and they turned around and sued Lakeview Anesthesia Associates in New Orleans or in Louisiana, where this doctor came from. They had written him a glowing letter of recommendation, even though they had knowledge at the time that he was potentially impaired from a substance use disorder. That doctor who wrote that letter was on the hook personally for half of the suit against Cadillac, so $4 million. Malpractice doesn't cover writing letters of recommendation. So there can be very real consequences to patients. These are dramatic cases. They're rare, fortunately, but this is the kind of fear that we're dealing with when we're talking about the public and stakeholders when it comes to physician impairment. And so I'm going to talk a little bit about how that relates to what it is that we do. So what impairs doctors? Substance use disorder, psychiatric conditions, medical conditions and their treatment. So cancer and cancer chemotherapy is an example. Cognitive and neurologic conditions. We see age-related impairment. We see cognitive impairment not related to age. 23% of individuals who are referred to WPHP demonstrate cognitive testing impairment on screening. So we use the MOCA. We change up the criteria for what we consider normal versus abnormal. We understand it was never designed for this purpose, but it's the best we've got in terms of evaluating just for a brief screen. Everybody gets screened for cognitive impairment coming in, and as I said, 23%. And that's actually consistent with the literature. So there is a literature on the rate of cognitive impairment by neuropsych testing of individuals referred for practice-related problems, and that's actually pretty much in line with what's out there. And the reason we started doing cognitive screening on everybody, because it turns out that cognitive problems are independent of referral question and age in this population. So we screen everybody that comes in. We also screen everybody that comes in with toxicology testing. Chronic burnout, distress, and personality pathology. Any health condition is fair game for WPHP. So what are the signs of impairment in physicians? Well, the things that you might expect, we call them the 6 I's. The 6 I's have been around for a long time. Irritability. So anger, irritability, low frustration tolerance, that's uncharacteristic of the individual, right? So there are some people that are just constitutionally irritable. And we know them, we love them, but we're talking about uncharacteristic or changes that we see even in the course of a day in somebody's irritability versus sort of being more calm or engaging. Negativity, cynicism, argumentativeness, overreaction to criticism. So these are the kinds of things that we might see that are new or different in someone. Irresponsibility, shifting workload, taking shortcuts, inaccurate or improper or inadequate overall documentation or work, and then taking shortcuts to catch up to cut work avoidance or not doing what one's supposed to do. Inaccessibility is just not being where you're supposed to be when you're supposed to be. So being tardy, not showing up, not having your pager or your mobile working, not being available when you're expected to be available on call or after hours, early Friday departures, Monday, and post-holiday illness. So these are times when people may be particularly susceptible to an exacerbation of their illness. They're trying to recover in time to get back to work and can't. And so they call in sick. Charting and order errors, inability in a variety of ways, not meeting milestones in training, being an outlier in terms of quality program within the hospital, not following policies and procedures, and difficulty with difficult cases. So, it's one thing to sort of do the routine work every day, but how does an individual respond when there's a difficult or a challenging case or a novel situation, and they have more trouble with that than we would expect for a high-functioning professional? Isolation, working odd hours, volunteering to come in early in the morning or late at night. It can be a sign that an individual is seeking access to drugs when drugs might not be under as much monitoring. Eating by oneself and not generally connecting with other people. Absence at meetings where it would be expected for an individual to attend. Not absence once in a while, but absence consistently. An individual who makes poor eye contact. The list goes on, but individuals who are struggling with these issues often feel intense shame. And they will not make eye contact, and it's noticeable if you pay attention. The incidentals, eyes, ears, nose, mouth, these are things that the usual stigmata of substance use, for example. So injected sclera, puffy eyes, runny nose, alcohol on breath, ominous warning sign. Ominous warning sign. We don't get very many referrals in the course of a year where it's a concern that somebody smelled alcohol on a physician's breath at work. When it happens, it's typically because the individual is still metabolizing alcohol from the night before. So they drank more than they intended, because that's a signature of addiction is inability to stop use once started, inability to not use. And so people use more than they intended. They're still metabolizing alcohol the next day. They smell like alcohol. What else? Things that you hear. So your ears. What's the reputation of this individual? This individual big partier, life of the party? Did they drive off in a huff from the gathering with friends last week, intoxicated and probably inebriated while behind the wheel? These are the kinds of things that people do observe over time. But oftentimes it's different observers over different time periods, and there's no real cohesion. There was a anesthesiology resident, R4, a couple of years ago at the University of Washington, who was found dead in the call room. In the days and weeks that followed, with inhaled anesthetic gas, that was the cause of death. In the days and weeks that followed, what came out is virtually all of the peers in the program knew that there was something going on with this individual. In retrospect, they wished that they had said something to their program director. In retrospect, their program director wished that they had gotten the information and could have served as a bit of a clearinghouse for these different observations over time relating to this individual, and that might have saved the individual's life, right? So it's not one thing. Somebody nodding off in a meeting is not impaired, in my view. It's really clusters or patterns and observations over time that suggest that something may not be quite right. So the barriers, big ones, denial. We're all subject to it, but as physicians, I think because of the intense shame, fear, stigma, denial is a big issue. It's not lying. So when people come in to see us, they're often very much in denial about what's going on. And, you know, one could argue, well, isn't anybody who say that they don't have a problem, you know, we just label that as denial. No, denial is an unconscious defense that we can see, right? It's a lack of insight. They're not seeing the world in the way that other people are seeing it. We can see sophisticated systems of rationalization and denial in physicians. In this way, impairment is very challenging in physicians because physicians have these big cortex, you know, frontal lobes that allow them to really spin a good tale, especially when they're trying to evade detection. And so this makes our work very challenging. And we have to work around that. But most of the time, they're lying to themselves as much as they're lying to us, if that's what we want to call it. And that's really what the unconscious defensive denial is that there's some unacceptable aspect of one's experience that we simply choose to not deal with. Ego, you know, so physicians are not only compulsive, but they're, I'd say, common trait characteristic is narcissism in physicians to some extent or another, in addition to avoidance. So if you wanted to look at the three big ones, it's compulsivity, avoidance, and narcissism is what we see most often in physicians. And it's really interesting to see how a physician would rather be in control and not succumb to the suggestions of others who have the skill, experience, and expertise in this field to know that there's a problem than they would to survive. You know, their license is at stake. They could lose their license. They could lose their ability to practice. Their family will be negatively affected by all of this. And yet their ego prevents them from being able to engage in a process that will ultimately be helpful to them. Fear, real or imagined. So there's no, I'm not here to deny that the fear that people would feel under these circumstances is real. If you're struggling with a substance use disorder and you're fearful of being detected, that fear is real, and there can be some real consequences of that and not. Coming to see me and doing my program is not an easy path, but you don't get the outcomes that you get with us by taking an easy path. And you got to do it if you're a physician, because the risk of you not getting adequately treated, the risk of undertreating you and putting you back into patient care situation is too high. Too high from the perspective of what might happen to a patient, too high from the perspective of what could happen to the profession if we allowed people who are putting patients at risk back into care. So there are some real things. There's real fear that people have about seeking help because they're afraid of how they're going to have to someday answer questions on a licensing application or on a credentialing application. I understand this. I am working right now, and we have revised the questions on the Washington State licensing application so that people will not have to answer questions about prior mental health diagnoses or treatment. They will only have to answer questions about whether they currently have a condition that negatively impacts their ability to safely practice. There will also be a safe haven provision that allows people who are known to WPHP, which will be defined, to answer no on those questions. So if you become involved with us, you get a special protection in terms of licensing in Washington. And that's sort of going on around the country. And we're working on that with the ABMS specialty boards to change the way they ask their questions. We're also working on it with insurers and other credentialers so that people will no longer be asked these questions, which are a deterrent to seeking care. So I don't say that the fear isn't real, but we can help manage it. The fear that should be there and is not real is the fear of what will happen if you stay sick, right? That you will kill yourself, that you will hurt a patient, that your substance use disorder will get worse and be untreated with catastrophic personal and professional consequences. Nobody believes those things are going to happen. Everybody believes that their career will be ruined by virtue of being outed. We're not going to out you. We're going to keep it confidential, quiet, get you treated, and get you back to work. Nobody's going to be the wiser. And you're going to have a great career. You're going to have a fine career. We have individuals in our program that are international stars in the medical field in their areas, and everything in between. Ignorance. This is what I referenced before. You just don't have the frequency of experience with this stuff. We don't to really know what to do when we're faced with these situations. They're too infrequent, and there's too much uncertainty to really know what to do. So myths, why don't we act? Well, we don't act because we have this belief that if somebody's not ready, if they really haven't hit bottom, if it's not bad enough yet, then they really aren't ready for treatment. And that's actually not true. And we know from the criminal justice system, for example, in the addiction literature, that coerced treatment works. That you can actually help people get better, even if they don't want the help at the time. You don't have to hit bottom. Everybody has a different bottom. And whether we're talking about addiction or we're talking about your bottom in terms of your depression, or your bottom in terms of your anxiety disorder, your bottom in terms of other things that might be impacting your ability to practice. The M-deity syndrome, again, that idea of doctors knowing better, that we somehow will be protected by our medical knowledge is a myth that we develop. I believe that it's actually a psychological reaction to the parade of death and illness that we see as medical students and residents, that in order to not personalize that, first we develop medical student syndrome, right? Where we think that we have everything that our patients are having, and we worry about our own mortality in the context of seeing this on a day-to-day basis. And then we fix it by imagining that, well, with my knowledge and experience, I'll be able to know early, I'll detect early the signs of pancreatic cancer if I have it, right? Not so much. So doctors don't really know better. In many ways, we are complacent. And in many ways, because we don't seek care and we don't have an objective personal physician, we do self-diagnose and self-treat, we are uniquely vulnerable. I think there's this myth within the PHP of false positivity, but I'm going to talk about that a little bit more. The idea that if you come to the PHP, you're automatically going to be labeled with some kind of impairing illness and be forced to do a monitoring agreement. That's just simply not the case. One is, we're under a microscope of scrutiny by all the stakeholders that are involved in what we do, and there are many of them. The licensing boards, defense attorneys, the Washington State Medical Association, other professional associations for the licensees that we serve. We virtually can't make a move without people kind of looking at what we're doing in our decision making, not to mention the employers and peers of individuals who have referred to us, for whom the decisions that we make have real implications for the ability of their organization to operate and function normally. So I think the other thing is, what would be the motivation for us to bring people into our program that don't want to be there? The program's paid for out of a license surcharge that you all pay. So I don't get any benefit monetarily out of signing up more people. And in fact, you could argue that better for me to sign up less people, right? My view is, I'm going to let a few fish go to not catch any dolphins. Okay. So we don't benefit from dragging people through our program who don't need to be there. That said, if we're dragging somebody through our program that doesn't want to be there, they need to be there, whether they like it or not. And we may not be happy about it, and they may not be happy about it, but we got to do it. All of this leads to ambivalence, right? Not indifference, but ambivalence. You know, I'm the sick individual. I want help, but I don't want help. I want help because I'm miserable. I don't want help because I'm afraid of what will happen if I reach out and let somebody know that I'm not perfect. I'm worried about a friend or a colleague. I'm ambivalent about what to do. I want to help them, but I don't want to tell somebody because I don't want to be a tattletale. We don't do that. We don't rat out our peers. You know, this is how we frame it. Does anybody have kids? Right? Kids start learning about tattling when they're like 3, right? 3, 4, 5, big tattling years. And, you know, it drives you crazy. But we tell them, like, it's not tattling if somebody is not safe, right? That's when I want you to come tell me, you know, that Johnny's got a sledgehammer and he's hitting your sister, you know, like that's when we need to know about it. And this is the same thing. So I think we have to get it out of our mind that what we're dealing with here is tattling or telling on somebody. What we're doing here is trying to help. And wouldn't this be a lovely drug? All of your cares, all of your indecision, all of your ambivalence would just wash away, or not. So impairment really does create this bystander effect in those of us who are in a position to have a front row seat to worry about somebody in our midst. And the question is, are we going to be able to overcome our reluctance to take action when there's somebody in need, especially when it's one of our colleagues, especially when it might be uncomfortable for us to do so. Our mission is to rehabilitate healthcare providers and protect public safety. And we walk a tightrope in terms of doing that. The physician in front of us, we want to help. We want to give them the best care, world-class care. We want them to have the best chances of getting better. Critics of the PHP system, on the one hand, would say that what we're creating is a safe harbor for sick docs who are going to hurt patients, right? So we have to be mindful of the fact that we have this other mission, which is public safety, and it's actually our primary mission. We go away. We don't exist anymore. There is no therapeutic alternative. There is only the board. And the board can only do discipline and public sanction. So we don't exist anymore in a world where we don't put public safety first. And if there's a perception that we're not first and foremost looking out for public safety and a reality, we won't be around for long. Because it only takes one really bad case where people start taking a look around, and if we're not doing our job with regard to public safety, then everybody who benefits from our program and our advocacy is at risk. And there are lots of people out there who go to work every day counting on the fact that WPHP is vouching for them. And if we stop vouching for them, their organization is not going to let them continue to work, right? So it's critically important that we pay attention to this mission. In serving the public interest, we could sometimes be criticized as being heavy-handed, as being coercive. And that often comes from individuals who have some knowledge about what treatment as usual is, but have no knowledge about what treatment is needed for physicians to get them back in the game. And it's a different ball game with physicians because it's a safety-sensitive profession. American Society of Addiction Medicine recognizes the unique needs of the safety-sensitive professional, whether we're talking about physicians or airline pilots. Airline pilots out of the game for a year. Out of the game for a year. That doesn't work for physicians. Physicians taking them out of the game for a year would be financially catastrophic for most physicians. You take an orthopedic surgeon who's got $40K a month in overhead and take them out of practice for a year, they're done, right? So we can't do that. So we front load our interventions to provide a high dose, high intensity treatment on the front end to safely get them back to practice. And our data and our model is that 80% of physicians, this was a 16 PHP study published in 2008. It's called the Blueprint Study, DuPont and McClellan. Over 900 physicians, longitudinally followed over 7.5 years, 80% relapse-free by random toxicology testing at the end. That's the gold standard. That's why it's called the Blueprint Study, because addiction medicine recognizes that physicians have the best outcomes when this model is followed. And so we don't question the model, but for some, it may seem like too much, but you know, we overtreat in medicine all the time. When the consequences of recurrence of illness are potentially fatal or too high risk, we err on the side of safety. So do some people get overtreated? Probably. But that's the risk when you're a safety-sensitive professional. We know that this therapeutic alternative to discipline works. We have data year over year. These are CMOs, graduate medical education program directors, our clients, who say, would they be likely to refer in a system where there's confidentiality, and would they be likely to refer in a system where there's not confidentiality and the board has to know? And the clear answer is confidentiality is more likely to refer. Our initial goals on referral are to decrease everybody's stress level and reassure the individual being referred that it's all going to be okay. And to take risk out of the equation. So at the point that somebody's usually referred, there's a question about, is this individual safe to practice? Can we return that individual safely to practice that day? Sometimes not, sometimes so. When they come in and see us, we're going to meet with that individual for a couple of hours. We're going to take a biopsychosocial history. We're going to do cognitive testing. We're going to send for toxicology testing. Our goal in that initial visit is, can you go back to practice today, or do you need to stay out of practice while we continue to get more information? And that a lot of times isn't necessarily dependent on the information that we get during that evaluation, but the circumstances of the referral. So if the circumstances of the referral are very bad, ominous in some way, and nobody's going to be comfortable with you coming back to work right away, and nobody's going to find us to be credible in sending you back to work that day, we're not going to send you back to work that day. We're going to get the answers that we need, because as I said, it is critically important that when we say somebody is safe to go back to work, the organization believes us. right? And we've established a reputation over 30 years that when we say that, the organization does believe us. This is how we keep physicians who have these kinds of problems employed in the face of the stigma that exists around impairing illness. We complete our initial assessment. Maybe we need a further evaluation. That might come in the form of a multidisciplinary substance use disorder evaluation, or if that's not on the table, then we might proceed with other types of evaluations. We may need neuropsych testing. We have specialists who evaluate physicians for neuropsych issues. We might need additional psychiatric evaluation. We have specialists, psychiatrists in the community, and addiction psychiatrists in the community who know physicians and physician health. Is additional treatment needed, and then does the individual need monitoring, or can they just go on their merry way because their illness is fine? Most of the folks that come to see us do not end up in a monitoring agreement. So I'm going back to this idea of false positivity very quickly. So last year, 189 people we got calls about. Of those, 130 actually came in, meaning there was enough signal coming off of that individual, there was enough credibility to the information that we received that we called that individual, invited them in. What do you imagine people say when we call them up and say, "Hi, this is Dr. Bundy from WPHP. You've never heard of me and you've never heard of our organization. How'd you like to come in for a little chat?" The answer is no thanks, but love you, Dr. Bundy. Keep doing what you're doing. So we need some leverage. Often that leverage comes from the employer, but sometimes it comes from the fact that we have a statutory obligation under situations like that. So our evidence is really, if this individual does not come in and meet with us, are we going to have to turn them over to the licensing board? If the issue doesn't really rise to that level for us, if we don't think that's a concern, then that individual probably won't even come in. But then of those that come in, of the original 189 that were referred, only about less than half really end up in a monitoring agreement of some sort. So we really try to get it right. Most individuals are cleared. We put concerns to rest. Really what I tell people is that when they come in, there's a question mark over their head. And none of us wants to be walking around with a question mark over our head, right? So what's nice is that oftentimes we can put that concern to rest, reassure everybody. And oftentimes we find stuff that needs work, and we can advise and counsel that person appropriately and get them connected with some resources, but we don't have to be further involved. We can be further involved if problems persist or things get worse, but we don't need to have them join with our organization at that point in time. Most of the referrals come from employers, the medical school, GME. Some come from the disciplinary board in the context of an already reported evaluation, not one that we've reported. Most of the folks that end up in monitoring agreements are for substance use disorders. That's also a function of the duration of time. Substance use disorder monitoring agreements are 5 years. Behavioral health monitoring agreements are 1 to 2 years, depending. We have a variety of different monitoring agreements and a variety of different elements of monitoring that we can employ. The point here is that we individualize the monitoring to the individual's unique circumstances. If an individual ultimately is in that final group that requires monitoring, it means that there is a serious illness present. That illness is in remission, because if they're in monitoring, they're not in treatment, right? If they're in treatment, then, and they're not yet back in the workplace under monitoring, it means that we haven't got that illness to where it needs to be for them to safely return to work. And because of the robustness of the monitoring paradigm, we believe that we'll catch relapse early. Relapse, whether it's regarded to substance use or any other problem. And we believe that the risk of relapse is at least comparable to that of the unknown population of individuals practicing out there. What predicts relapse? Use of a high-potency opioid. So anesthesiologist diverting fentanyl, classic example, right? That's going to predict relapse for a substance use disorder. Comorbidity, so comorbid psychiatric diagnosis, family history. Specialty doesn't predict relapse, and anesthesiologists are safe to go back to practice. That's usually always a question. So satisfaction, this is proportion of individuals that report a 6 or 7 on a 7-point Likert scale for satisfaction with WPHP. Most are close to or north of 70% of individuals highly rate their satisfaction. 45 to 50%, depending on the year, describe their involvement with WPHP as life-saving. Over 90% agree that it's at least moderately useful or better. 100%, some year this is going to change because somebody's going to say no. But until then, I'll keep showing this slide that shows that, you know, treated with courtesy and respect, great health outcomes in terms of general overall health. It's a little bit of a confusing chart, but orange and purple is agree or strongly agree with the idea that in the domain listed, their circumstances have improved by virtue of their participation in WPHP. Meaning, were it not for my participation in WPHP, my overall health wouldn't be as good as it is. And that's 70% of respondents, right? So you can see some pretty good overall impact that's not necessarily directly correlated or related to the impairing illness. What we like to say is that the benefits of PHP participation extend beyond just the impairing illness. And again, our data coheres with the data nationally in terms of relapse statistics. What you should notice from this is that of those that relapse, which is a small number really over a 5-year period, what's the relapse rate in usual treatment for individuals who do, say, a 28-day rehabilitation program who are housed and employed in the community? How many people will be sober at 6 months? What percentage? Anybody know? Yeah, 40%, right? So 40% versus at 6 months versus 80% in physicians at 5 years. And of those that relapse, 12% or 2/3, one and only one relapse. So therapeutic relapse, we figure out what was missing in their recovery program, we fix it. Burnout. So we use 2 burnout measures validated by West and colleagues, similar to how Shanafelt at Mayo measures it. And what we can tell you is that it's well less than half the rate of burnout in our participants versus physicians in the general population. These are people that are out there practicing in the same healthcare system that everybody else is practicing in, yet somehow they've developed resiliency factors as a result of participating in our program. At the end of the day, 90% of individuals are never known to the licensing board. Of the 10% that are, 5% were referred to us by the board, and less than 5%, probably 5 or 6 were referred to us by the board, and probably 4% are individuals who cannot or will not collaborate with us, work with us, and we ultimately have to turn them over to the licensing board. That is the last, that is our very last thing that we do when we can't figure out a path forward. But 90% are working in the program at completion, and there's a decreased malpractice risk for individuals who have participated in PHP. In summary, physicians get sick like everybody else. We're held to a higher standard. Fear, shame, and stigma are the enemy because they make it harder for us to get into treatment, to acknowledge illness in ourselves. We have characteristics that make us harder to identify and harder to treat. We are not peachy keen when it comes to getting into treatment. We're not easy to treat. We know too much for our own good, but we have really good outcomes once we engage. PHPs across the country, there are 47 of them. WPHP is one of the oldest, most well-known, most respected. So if you happen to have a problem here in Washington, consider yourself lucky. We'll protect your life and your career if you get sick. We're a safe place to land. Thank you. I'm over time. I planned for an hour, but we started late. So I don't know if I can hang around for questions for people who can stay, but please, you won't offend me if you get up because I know you have busy lives and things to do. Yes?
Is there information out there with respect to male-female suicide rates? Is there information out there about societal gender norms? So women's roles are generally diminished in society or compartmentalized or marginalized. And that translates over into the professional workplace as well.
Mm-hmm.
So if it is the case that in society, women at least have a place in the home or wherever, but now they're professionals and they don't even have a place in their own profession, could that be a component of why that risk is increased? You know what I mean? Is it convoluted? Too convoluted?
A little. I'll be honest, but
the examples that were brought up seem to vary. Like you could have a family at home, or you could not. As a woman,
right.
You could be more empathetic, or not as a woman. But I think everyone agrees that women generally face discrimination. That's what that was. Discrimination outside and in the hospital.
So if anybody's actually still online out in the universe, the question was really about, I think, is there a role for women or gender disparity in suicide risk based on I guess what I would consider role identity or confusion, and the differing roles that women have vis-a-vis men. I can't say that I'm an expert on that. I could say that's been postulated. I would invite my support in the audience, Dr. Sung, to offer his views on this. If you know if there's, you asked if there was literature or data, and I don't know that there is.
Whether it's quantitative or qualitative, just wonder if there's like places I could read up.
I think women, in terms of the role identity issue, are can't win, right? Because they're bad moms if they choose a career, and they're bad careerists if they choose momming. And I think that that's a difficult bind for women to be in. That is often not true for men. And it's interesting that in dual physician partnerships that are male-female based, the female typically takes on traditional gender roles in terms, and a disproportionate amount of the, homemaker responsibilities versus the physician male in the group. So it doesn't matter, in fact, that they're both physicians and both have this, professional life, that it typically still falls more to the female in the partnership to take on those roles. Yes, sir.
Chris, in treating female professionals as opposed to male professionals, one of the different factors that came up in therapy was not just the expectations of being a mom or being good in your profession, but perhaps an unanticipated adverse effect of the feminist movement. Because regardless of how well they were doing as mothers, as professionals, they always fell short of the Virginia Slims image.
Yep. Other thoughts on that comment, or questions about the program or what we do? Thank you. Appreciate it. Appreciate your time. I think we should end. I'll hang around. Thanks to all you out in the electronoverse who were patient to listen.